This presentation is on the concept of perfusion. So we're going to define and describe the concept, note some risk factors for having impaired perfusion, recognize when the patient has compromised perfusion, and discuss some appropriate nursing and collaborative interventions to optimize perfusion. So when you think about perfusion, really, the definition is the flow of blood through arteries and capillaries, and it delivers nutrients and oxygen to the cells. Simply, perfusion is circulation. Circulation to all target organs, to all cells, to all arteries, to all veins, everywhere. Can we see perfusion? Sure, we can see perfusion. When somebody has warm pink skin, we know that their integumentary system is being perfused. They have stable vital signs. Their cardiac system, their heart is being perfused. If they have adequate urinary output, which is 30 milliliters or more per hour, they have renal perfusion. They have strong peripheral pulses. They're alert and oriented. We can determine that that is their cerebral perfusion and that they're okay when they have good perfusion with that. So how do we know if there is impaired perfusion? Well, the patient fortunately tells us a lot of things. Respiratory-wise, the patient will be hypoxic, hypoxemic, be short of breath. So we're going to see cyanosis. We're going to see their respiratory rate increased. That's the body's compensatory mechanism to get more oxygen to the tissues. Now, the oxygen is supposed to be carried by the blood, which is the circulation. When that's a problem, many of our systems are affected. Just as I said, the integumentary, somebody has a problem with that, we're going to see cool, moist skin, cyanosis. They may have edema. You know, the venous system is responsible for pushing everything back to the heart. So when people have peripheral edema, that is a problem with fluid overload, or it's a problem with their veins, that they cannot get that blood back to the heart, so it can be part of central circulation. So cardiac, weak peripheral pulses, tachycardia, and hypotension. So tachy and hypotension are the hallmark signs and symptoms of anybody who has hypovolemia. That is the body's early response. When there's not enough blood flow, there's not enough oxygen, the brain tells the other systems to make the heart beat faster, which in fact does worse for the situation, because as we talked about in gas exchange, when the heart is beating very fast, cardiac output is significantly reduced. That means that the chambers don't have any time to fill with the blood, so there's no blood flow being propelled out to the body. Renal problems with perfusion, you're going to see, number one thing is going to be a decreased urinary output. You will also see, different color changes for the urine. It may look more like Coca-Cola. It may be amber. It may be orange for lots of reasons. Cerebral changes, change in the LOC, or level of consciousness. Just from lethargy to being very obtunded to stuporous to a coma. Any of those things can occur. Gastrointestinal, this is also one of the areas that suffer from decreased perfusion. There'll be a breakdown or a slowdown in the digestion. Patients will develop ulcerations sometimes, and they can actually, frankly, lose blood from those ulcers. And then there's translocation of bacteria, which leads to sepsis. So how can we improve perfusion? We have to fix the problem. We have to figure out what the problem is. Most of the time it's fluids. Maybe the patient is dehydrated and the blood pressure is low and they're tachycardic because they're in a fluid volume deficit. We can give them 1 to 2 to 5 liters of normal saline or lactated ringers, which are isotonic fluids that will just increase volume. If they need blood products, we can give them packed red blood cells. We can give platelets. We can give volume expanders such as Hespan to improve the volume in the vessel. We can give oxygen. Sometimes that will help with some perfusion, just getting more oxygen on board when we don't have good oxygen in the blood, and also positioning. If your patient is hypotensive and they can tolerate it, the first thing that you should think about doing is lowering the head of their bed and elevating their feet. That's going to use gravity to get the blood flow back to the target organs. So some key terms when we're talking about perfusion. Ischemia, that means lack of blood flow, and it can be and is typically temporary. When we think about somebody who is having angina or chest pain, that is ischemia to the heart. They don't have good blood flow. Either they have, blocked coronary arteries, they have a constriction in their coronary arteries, they just don't have enough blood flow, and the coronary arteries are not perfusing the myocardium. Infarction is one step less. That is after ischemia is not reversed. That is actually cell death. Myocardial cells do not regenerate themselves. So when there is damage to that area of the heart due to blocked blood flow, anything distal to that blood supply is dead and becomes either akinetic, which means it does not move, or hypokinetic, which means that the wall doesn't move very much, and so cardiac output is pretty significantly reduced. And anoxia is lack of oxygen, which can also be due to lack of blood flow. So there's a couple kinds of types of perfusion. Central perfusion is basically the blood flow that is coming from the heart. This is our cardiac output. Normal cardiac output for an adult is 4 to 6 liters per minute. So that is a lot of blood that the heart is pumping in and out every minute. In order to have good central perfusion, we have to have good cardiac function, we need to have a good blood pressure, and we need adequate blood volume. Cardiac output is stroke volume times the heart rate, and the stroke volume is how much volume of blood is moving out of the heart with each contraction. And then heart rate is multiplied by that, and that's how we get the cardiac output. So central perfusion is dependent on preload. You may remember that if you've had that in anatomy. So preload is the amount of blood that's left in the ventricles at the end of diastole. At diastole, that is when the heart is at rest and the ventricles are filling. So diastole is also the term we use for the bottom number of your blood pressure. So it is much more relevant if somebody's diastolic blood pressure is 90, 100, 120, because that's when the heart is supposed to be at rest. So the heart is under a lot more stress during that time and has a lot more incidence of being damaged. So preload is also the amount of blood that's presented to the heart from systemic circulation. So things that can affect preload if your patient's dehydrated and they're in a fluid volume deficit. If we over-diurese the patient, then they're not going to have as much volume presented. Preload is blood presented to the right atrium of the heart to take part in cardiac output. So another thing that affects cardiac output and central perfusion is afterload. And afterload is also called systemic vascular resistance. So this is how much pressure it takes for the blood from the left ventricle to get through the aortic valve. How much pressure does that left ventricle have to push to propel that blood through that big aortic valve and out through the aorta and to the other parts of the body? And that is why the left ventricle is much thicker and much stronger than any other chamber in the heart, because it has to fight against that pressure to get that aortic valve open. So local perfusion is volume of blood that flows to our target tissues, the organs. We have to have patent vessels. We have to have open arteries, open veins. We have to have adequate hydrostatic pressure, which this is the pressure from the force of the ventricular contraction. So that helps open, that little oomph at the end helps open up these capillaries and keep them open so gas exchange can occur and perfusion can occur. This is a schematic that comes from your book, I believe, and it basically is just a review of the central perfusion. So of course you see blue, that means unoxygenated blood, and the red is the oxygen side. So the blood returns from the systemic circulation into the right atrium. It goes through the right AV valve, which is also called the tricuspid valve, into the right ventricle, and on through the pulmonary semilunar valve. So this is the tricuspid. This is the semilunar. So the blood goes in the pulmonary artery, which is the only place in the body that I know that is an artery, but it carries deoxygenated blood. So this blue blood is going here. Magic happens in the lungs. So pulmonary artery, lungs, arteries, arterioles, capillaries, venules, and veins. So this blood then will come back through the system from the lung, through the pulmonary vein, where it's nice and red, it has a lot of oxygen, goes from the pulmonary vein into the left atrium, through the mitral valve, through the left ventricle, and then the left ventricle propels that blood out the aortic valve, and that goes to the aorta and to arteries of each organ and arterioles. So that is just a review of circulation. So impairment of central perfusion occurs for any reason that cardiac output is inadequate. So factors that can cause a decrease in cardiac output, number one, frank hemorrhage. Your patient has been in a motor vehicle accident, they have lacerated their liver, the liver is has a pretty significant blood flow, so they've lacerated that and they're having internal bleeding from that. So that blood is leaking out into the abdominal cavity, and that blood is no longer available to be in the vessel to take part in circulation, to take part in cardiac output. Other volume losses, as I said, dehydration. If we're not taking enough volume in, the body will shut down the urinary system and tell the kidneys do not let go or make any urine because we don't have enough volume on board. So if you've ever had the flu and you're dehydrated, your urine is really dark and you're really not voiding very much. That's the reason. The body is telling the kidneys to hold on to it. If we over-diurese patients, say, with Lasix, any of those loop diuretics, which work really well, we can actually put our patient in a fluid volume deficit to the point where we can cause them to have an acute kidney injury due to what's called volume contraction. Not enough blood flow going to the kidneys get an insult and they're unable to do their job. Another volume loss is a relative loss, and it is from vasodilation. There are lots of blood pressure medications out there that particularly that's what their job is. Their job is to vasodilate, loosen up, make these vessels larger so the blood pressure is not as high and causing so many issues with that. Other things that cause vasodilation is sepsis, which is infection in the blood due to bacteria, anything like that. The endotoxins from the bacteria will actually damage the walls of the vessels and cause them to also vasodilate. And we may have all the volume on board that we need, but it is just a little trickle of volume in this big vessel that's been vasodilated. The body doesn't know any different. It just doesn't have the preload returning, so it doesn't have cardiac output and afterload. Other things, if there's decreased blood flow to the myocardium, that can be due to valve issues. Patients can have valvular stenosis, which means that their valves are rigid and they're not opening all the way, so there's decreased cardiac output from that. They can also have regurgitation in any of their valves, which means that the valve is then incompetent and doesn't close all the way. So what happens is the blood is free flowing from atria to ventricle, and again there's a reduction in the cardiac output. The elderly will have some electrical or conduction issues with their heart. That happens as we age. so they don't have electrical impulses to fire to make that ventricle contract, which again reduces cardiac output, or any coronary artery constrictions or blockages. As I said, anything distal to that reduction in blood flow is going to be infarcted and is not going to participate in cardiac output. Some of these, if severe, reduction in cardiac output, but for whatever reason, is mostly associated with shock, hypovolemic, anaphylactic, septic, any of those things. Neurogenic can impact any of those and cause poor cardiac output. And if anything is left untreated, first we have ischemia, which is a little bit of damage due to a temporary measure. Then that leads to permanent cell injury and cell death. So variations of tissue perfusion. This is problems with vessels, patency or permeability, or as a result of inadequate central perfusion. So factors that can impair or reduce tissue perfusion are occlusions, which can be seen as a thrombus, which is a blood clot, something that's blocking the artery, blocking the vein. Atherosclerosis, which is basically coronary artery disease. That can be from elevated lipid levels, cholesterol, triglycerides, those things that are damaging and making the lumen of the vessel smaller, which increases the amount of pressure that blood has to go up against that wall and causing damage. Also, you just had diabetes mellitus, so you know that diabetes itself causes a lot of cardiac disease. And obesity, a problem everywhere, but obesity will also reduce people's ability or their desire to be active, so they have a lot of downtime, a lot of sitting problems with their vessels, and it also is a precursor for them to develop diabetes, which leads all the way back to this vicious circle. So another one is constriction. So vasoconstriction can occur. That can happen because of sepsis. That the most primary reason we see is as a result of nicotine. Nicotine is a very powerful vasoconstrictor in the bloodstream, and also hypertension that is not controlled. And then another reason is dilation of your arteries or veins, and typically that can be, as I said, from sepsis, or it can be due to an aneurysm. So if we were in class, we could look at each other and consider the person sitting next to you and make some lists about whether or not they have optimal central perfusion. So if we thought that they had poor perfusion, we could see things such as a decreased hair pattern on people's legs. You'll see that a lot in the hospital. You see cool skin in the periphery, weak pulses, particularly those distal pulses like dorsalis pedis, and also a brown discoloration pattern coming up from the feet and up into the shins, and that is actually related to a peripheral vascular disease. So inadequate central perfusion, it affects all age groups. So for infants and children, they can have poor feeding, poor weight gain, a failure to thrive, and a dusky or cyanotic color. Dusky is kind of a purplish pink color, and all of these things are typically related to their inability to suck and dyspnea. Most of the time kids have congenital heart defects, which cause central perfusion issues, and they just don't have enough energy to actually take nutrition in. Toddlers and children, very common for them to squat and have fatigue, because this is due to impaired tissue perfusion and central perfusion. They squat, and that kind of shunts the blood from the legs and stops it from going into the legs and keeps it all shunted to the core of the body. Also, they can suffer from developmental delays and failure to hit those milestones. So here's some pictures that I drew myself, And this is, in talking about the heart and coronary artery disease, which we'll talk about, this is a normal ECG complex. So you'll see that there are 5 waves. It's the PQRST. The P wave is the very first upward rounding, I guess, can't think of the word, in this complex. And that shows you that if you have a P wave and it is rounded, looks like this, then that is the atria depolarizing. So that means that it's likely the SA node, which should be the pacemaker of the heart, and it is having an electrical impulse, and it's firing, and it's going down into all the areas that it goes to. It goes to the goes through the P wave and the SA node, goes through the AV node. Then from the AV node, it goes into the bundle of His. Then it goes to the Purkinje fibers, and that's what causes the ventricle to contract. And this is known as systole. So this is the cycle of the contraction that gives us our top number of our blood pressure. So the ventricle depolarization is seen in the QRS. That's when the ventricles contract, forces the closure of the mitral and the tricuspid valves at the same time. Blood is propelled from the right ventricle to the pulmonary artery, and from the left ventricle to the aorta to the body. After contraction, the pressure decreases in the ventricles and the chambers begin to fill from the left atrium to the right atrium, and that is known as diastole, or your bottom blood pressure number, and that is again when the heart is at rest. So we don't see atrial repolarization in this complex because it is buried in the QRS, but the QRS is the depolarization of the ventricles, so that's the contraction. The ST segment is there, and we see a couple of different things in that on the next slides. And then the T wave is another rounded upward wave, and that represents ventricular repolarization, where the ventricles are recovering and starting to fill. So all of that is normal. This shows depression, ST depression. If you'll see, figure out these. This is the baseline. So everything should be, that's not a straight line, everything should be meeting at that baseline. So you have atrial depolarization, we have an SA node firing an impulse, goes down, there's atrial repolarization, which we don't see. We see the QRS here, and this is the ST segment. As you see, this is well below the baseline, and then it goes right back up for the T wave. Everything looks normal here, except for this ST segment is sagging below the baseline, and that is ischemia. When a person is having chest pain or angina, there is decreased blood flow, there's decreased oxygen, and we literally see this in the EKG. We can fix this if we catch it in time. We can give the patient oxygen, which will help. We can also give them nitroglycerin, which will vasodilate, and it will decrease the myocardial demand on the heart. And hopefully, once we get oxygen and blood flow back to the heart, this will go right back to being a normal complex. So ischemia is depressing. This is elevation, and ST elevation only means one thing, and that means a myocardial infarction. So of course this is abnormal. So we've got another P wave here, SA node firing, QRS. But right here, when we'd like for the S to go back down to the baseline and come back up, we have this area where it is elevated. And ST elevation equals myocardial infarction. At this point, we're not going to stop anything. The best we can do at this point is to stop the process or halt the amount of cell death and myocardial muscle death that is occurring at this time.